So the OR I'm going to refer to for much of this presentation is referred to as operations research, and then we'll talk about applying OR in the OR as well. So what is operations research, this type of OR? It's a systematic way of thinking about management and decision making. So it involves applying advanced analytical techniques to try to make more informed decisions and have a way to make trade-offs and look at the cost benefits of different decisions under uncertainty. So it involves typically using data-driven models, mathematical models, computer models, to have a rigorous way to balance costs and benefits under different treatment options and system configurations. So it helps managers make tough decisions, solve critical problems, and shape important policy. Okay? And it can be applied to both addressing long-term planning as well as day-to-day operational challenges. So it's sometimes referred to as the science of better, or science of better decision making. So a little bit about the background. A lot of the development of OR arose during World War II applications in terms of trying to get goods and supplies to the front lines most efficiently, trying to search for submarines, enemy submarines, effectively, and efficiently using radar technologies. Since then, it's expanded to be used in a wide variety of application areas. So manufacturing is a big user of operations research techniques. It's used in inventory planning, supply chain management, telecommunications, and healthcare has been using OR techniques much in the last 10 to 15 years. So just to give a flavor of some of the questions that operations researchers analyze in a non-healthcare context, you have these types of problems. So what is the most efficient way to route FedEx trucks to make deliveries so as to make all their deliveries and return back to their home base using minimum amount of fuel, minimum distance traveled, for example? How much inventory should Walmart reorder each month? There is uncertainty as to what the demand will be each month, so they have to make a decision trying to balance understocking with overstocking. How can Disney World reduce the average time customers wait in lines? And airlines use operations research a lot. So how should an airline schedule its pilots and flight attendants? How many seats should they sell at the different price points? So as Dr. Guan mentioned, I worked for United Airlines for a few years, from 1999 to 2002, and I was working in the revenue management department, which is the department tasked with the decision of how many seats to sell at different prices to try to maximize revenue. Unfortunately, United went bankrupt while I was trying to help them maximize revenue, so I decided that was not my calling in life, so I decided to go into healthcare analysis. I don't know what that means for the public, but so operations research in healthcare, it's, as I mentioned, it's been increasingly applied in the healthcare context in the last 10 to 15 years. Reasons for this? Well, many of the developing countries are seeing a rising percentage of their GDP attributable to healthcare. So there's a push to try to find more cost-effective ways for delivering healthcare. Also, more treatment options have been becoming available, and it's become more difficult for patients and physicians to figure out which of these treatment options is best. There's much uncertainty as to how things will play out under these different options. So we would like some tools to be able to balance the different costs and benefits. So here's some examples of OR in healthcare. How should we schedule nurses, physicians, exams, and surgeries optimally? How many beds should there be in the ER? Where should ambulance bases be located to provide adequate coverage to a city? Okay. How should resources be allocated to control infectious disease outbreaks? Who should be vaccinated? Who should be quarantined? So a lot of people are doing modeling in ID outbreaks. And what is the optimal time to initiate HIV therapy? So this last question was the topic of my dissertation research. So I don't know how well you could see this, but this gives more of a flavor of different applications of OR. And on this link, we see finalists and past winners for what's called the Adelman Prize from the Institute for Operations Research and Management Science. So this prize goes to the best application of operations research. And you could see a wide variety of industries from Coca-Cola to HP and the U.S. Coast Guard. And it turns out the winner in 2007 was from Memorial Sloan Kettering Cancer Center on applying operations research to improve cancer therapeutics. And I'll talk more about what model they were looking at primarily in a couple of slides. So some healthcare OR projects that we've been involved with at the Sauder School of Business with various BC health authorities and organizations are listed up here. So we've looked at efficient porter operations at Vancouver Coastal Health and Providence Healthcare, improving patient throughput at BC Children's Hospital. So Dr. Guan and I are co-advising Candice Chan, who's right here in front. She worked on that project for her master's degree, and now she's working with the Department of Urology, doing an internship and trying to apply some of these techniques of operations research to improve processes there. Okay, improving surgical patient flow at Royal Jubilee Hospital. That's another project that Vincent Chow, who's also here, worked on for his master's degree project. And residential care capacity planning for Vancouver Island Health Authority. So these first 4 bullets are projects that our master's degree students at our Center for Operations Excellence worked on. So that involves students doing a 4-month study with an industry partner, and these are some of the projects they did. The last 2 projects are part of a collaboration we developed with the BC Cancer Agency through a CIHR New Emerging Team grant. One of those projects is to look at how to reduce patient wait times at the BCCA Ambulatory Care Unit, and looking at the strategic scheduling of radiation therapists at the BCCA. This last topic is a topic of one of our PhD students, and 2 of our master's degree students have gone on to work full-time as operations research analysts at the BCCA, looking at some of these studies. Vincent is one of those. Okay. Now, in terms of looking at OR and urology, okay, one of our PhD students is looking at this first question. What is the optimal time to switch from neoadjuvant hormone therapy to radiation therapy for treating prostate cancer? She's working with Dr. Scott Tildesley at the BCCA on this. Other projects applying OR and urology include deciding between watchful waiting and radical prostatectomy. What are good prostate cancer screening policies? Okay, balancing costs of screening with timing them so that you identify the disease. This 4th bullet, optimal placement of radioactive seeds to treat prostate cancer with brachytherapy. This is the topic of that Adelman Prize winner that I mentioned a couple of slides ago. So those first 4 look at questions around prostate cancer. The last 2 look at questions around kidney transplantation. So one of them is, what's the optimal control of a paired kidney exchange program? So some donors and their intended recipients, spouses for example, one can't donate to the other, and another pair of spouses, one can't donate to the other, and there's a bunch of these pairs. How should we match some of these blood type incompatible people with people from other pairs effectively? What's the optimal allocation of kidneys to patients on the waiting list? Okay. I'll talk about my involvement in looking at the optimal allocation of livers to patients on the waiting list and make the analogy to this kind of question, which is the last bullet. So I want to talk about one tool in particular that we use often in operations research, which is simulation modeling. So this is widely used for looking at complex processes in which there's a significant component of variability. Okay. So this allows us to have a tool for doing what-if types of analysis. Okay. What if we had an extra physician? What if we purchased that extra CT scanner? And so forth. So it's a computer model in which we could play around with different scenarios, look at how they might play out within the context of this model before we go commit ourselves to making actual changes to the real system. So it might be too expensive, it might be too time-consuming, risky, and so forth to take a trial and error approach to making changes to a real system. And so we like to have these kinds of computer models to play around with before we make such big decisions. Okay. So we see examples of this in resource planning in healthcare facilities, ambulance location, as I mentioned before, and organ allocation policies. So let me just jump to this to give you a flavor of a classic type of simulation is that of an emergency room, okay, where you simulate the random arrival of different types of patients to the emergency room. They go to different stations, they go to a triage nurse, they go to registration. It takes some time, varying amount of time, to process patients at those different stations. Then there's some number of beds in the emergency room, some number of physicians, nurses, and so forth. And each patient takes some different amount of time to be processed at these different locations. So questions we might explore with this type of model are staffing questions. How many nurses should we have? How many physicians should be on staff at different times during the day? How many beds should there be? And so forth. And so we could play around with these questions in a model like this and try to inform decision making. Okay, so I want to talk a bit about my involvement in this model of end-stage liver disease and the liver allocation process in the US, and knowing that a lot of these techniques could be applied if we want to model end-stage renal disease and kidney allocation, which we've been discussing about considering doing here in BC. So the problem is that there's, as Dr. Seth was mentioning, there's a big mismatch between supply and demand. Approximately 16,000 patients are waiting with end-stage liver disease for a liver donation in the US. Now, unlike for end-stage renal disease, where dialysis is an option, for liver disease, liver transplantation is the only viable therapy. So therefore, allocation policies for liver donation have serious implications for health outcomes, and this is a rather contentious issue that tries to balance issues of efficiency with equity. So different geographic areas want a fair representation of patients in that area getting organs, and so forth. A randomized controlled trial is just not feasible in this type of context. It's not even clear how you would even conceive of one. So this is where simulation provides a rigorous means to look at biologically based estimates of how different policy changes, different allocation policy changes would affect patient outcomes. And we could look at a variety of patient outcomes of interest. What's the average waiting time for a transplant? How many people die while waiting? What's the average post-transplant survival time? And so forth. So this is how the U.S. is broken up into different organ procurement organizations, or OPOs. So if an organ donor dies in Chicago, say, OPO 31 is responsible for going and harvesting this organ and letting the United Network for Organ Sharing, UNOS, know that they have this organ that's available for donation. So there's different levels of this allocation policy, as we'll see. So we'll have to keep in mind this OPO idea here. These OPOs get grouped into different regions, which are indicated in this picture. And now these get considered in the allocation policy. So basically the way the organ allocation policy works in the US, or at least the way it worked when we modeled it, is as follows. So in the purple shaded triangular region there, you have the idea of urgent patients. Okay? And in the other part of the circle, you have some less urgent patients classified according to perhaps what's called the MELD score, or identified by different status levels. So if an organ becomes available, an OPO retrieves that organ and first offers it to the most urgent patients in that OPO, okay, in that local geographic area. If there's not a match or the patients refuse the organ, then they search in that region area that I showed on the previous slide. Okay. So again, they look for blood type matches if the patients want to accept this offer or not. If there's still no match, then they go back to the local area and they look for among the less urgent patients, ranked in some fashion, to see if there's a match there. If there's no match there, then they go back to the region level, looking at the less urgent status patients. Finally, if there's still no match, then they'll offer it to anybody in some outside region elsewhere in the US. Okay. So now, at this point, the organ could travel conceivably anywhere in the US, whereas before it was somewhat constrained to local geographic areas. Then they go to the most urgent here, and then finally they'll offer it to anybody in the US. So it's a somewhat complicated allocation policy, and this is where we would like some model to say, how does this allocation policy compare to other allocation policies we might think of trying? What if we said, forget this local geographic preference idea, and we just immediately offered it to the patient across the US who needed it most? So let me show you some information about the model structure. So we have, in our computer model, we have a patient generator. And we look at historical breakdowns of how patients presented with end-stage liver disease according to age, gender, race, blood type, and so forth. Now, when they enter onto the waiting list in our computer model, we update their patient health, their natural history, before receiving a transplant, so that when an organ becomes available, we have the updated patient health so that they could be prioritized in some way to figure out who should this organ go to next. So we have this quantitative natural history modeling that updates patient health, say daily or monthly. Some patients get removed from the wait list for various reasons. Either they get better or they become too sick, for example. Some patients die while waiting. So these boxes are indicating output that we might record with this type of model. Number of people that died prior to receiving a transplant, which is of considerable interest. So we have patients entering the model. We have organs becoming available for donation. So similarly to with the patients, organs, historically, we look at how they arrived according to age of the donor, race, gender, blood type as well. Okay. And now it comes time to figure out who this organ should go to next on the waiting list. So we have some allocation policy in place. So we start by modeling the allocation rules as they existed at the time to try to validate our model. And then from there, we'll play around with alternative allocation policies to see how they might play out in this kind of model. Okay. If an organ gets transplanted, we record how many of those happen, and then we have a different part of our model that looks at post-transplant survival. So there's two things that might happen after an organ is transplanted. One is that the patient might need to relist for another organ transplant. So we look at that, the post-transplant graft survival. So they might need to end up going to relist on the wait list, or they might die and never need another transplant, and we consider that as well. So a little bit more on the natural history modeling. So as I mentioned, we want to update patients' health periodically in the model, every month or every day. However, actual laboratory values available to us are not taken at these regular intervals. So more data are obtained when patients are sick, fewer data are obtained when patients are healthy, and so we need some way to estimate monthly transitions if that's how we're updating our patient health in our model. So this is an example of some laboratory measurement, I forget which one, but for a patient over time, these are actual laboratory values. And so what we do is we use this technique called cubic splining to fit some continuous curve to the data. So this is a linear regression. This is one type of cubic spline. We could have cubic splines that indicate that are rougher splines to capture more of the variability of the fluctuations in these laboratory measurements. Okay? So those are different types of curves we might fit to the data. So we chose one of these rougher splines to represent the fluctuations of these values. And then what we do is for different patients, for all the patients in our model, we construct this natural history cubic spline. So these are, for example, patients with primary biliary cirrhosis and different patients and what their data, what kind of splines they would generate. These vertical hash marks are to indicate that we're splicing these up into daily intervals to estimate patient health transitions for these different laboratory values over time. Okay, and then we look at triplets. So we look at day 1, day 2, day 3 transitions, then day 2, day 3, day 4 types of transitions, and so forth. And then we take all these triplets and we basically, you could think of that, we throw it in a bucket, we shuffle them up, and I'll show you how we use them in a second. But we want to get some sample of how these patients transition over these different time periods. For patients with hepatitis B, okay, we would filter out those patients and create splines for those patients separately and use this technique and have this hepatitis B bucket with these different time 1, time 2, time 3 transitions shuffled up in there. Okay, so in our model, we might have a simulated, say, 42-year-old male patient with hepatitis C, and we've recorded their laboratory value last period, the current time period, and now we need to estimate their next time period lab values for these 5 different lab values. So what we do is we look in our hepatitis C bucket of patients, and we have some nearness criteria to look at which one of these patients, okay, from our data set looks similar to this simulated patient in terms of these previous 2 laboratory measurements for these 5 lab values. What was this actual patient's next set of measurements? That's the T+1 over there. And then we assign that next set of measurements to be the simulated patient's set of measurements. And we keep iterating like that throughout our natural history model. So that's one key component of our simulation model for organ transplantation, is the natural history modeling. Then, after a transplant occurs in our model, we need to figure out, is this patient going to need to relist, or is this patient going to die before that ever happens? And so we use what are called Cox proportional hazards models to build survival curves of patient survival and organ survival. And we generate a time from each of these. And if patient survival time is generated to be greater than liver survival time, okay, then the patient is relisted at some time for liver failure. If the patient survival is less than the liver survival that we generated, then the patient dies at that survival time. So these are the key components of our model. And again, we think we could use these ideas to simulate end-stage renal disease and kidney allocation in BC and throughout Canada. How do we validate these models? Well, there's different steps of validation along the way. So early on, before we even start building a model, we have a level of face validity. So we have a National Clinical Oversight Committee that checked that our model assumptions were reasonable before we even dove in and started building the model. Some of these components, the natural history model, the post-transplant survival model, we validate those along the way. With a large model like this, you don't just wait until the end to validate it. You do it in steps, and you validate big components along the way. Finally, we want to compare actual UNOS outcomes with outcomes from our model. Okay? So how did actual patients fare in terms of number of transplants? How did our model predict number of transplants over these different years? What were the number waiting on the wait list at the end of each year in our model versus on the UNOS wait list? How many deaths were there while waiting? And what was the average waiting time for a transplant? And so we compare these, we get some level of comfort. If we're not comfortable with some of these, then we go back, we refine these models until we come to a conclusion that we're comfortable that these are close enough that it's a useful tool for decision making, or for trying to inform decision making. So we validate a model. That's not where we want to stop. We don't just want to validate a system as is. The idea is to try to make improvements. So here's where we take our model and we test alternative policies. And so at the time, UNOS was using this 4-status policy, status 1 being most urgent, and down to status 4 being the least urgent. And so we compared the 4-status regional policy, which is what was in place at the time, to 4-status national policy. So like I was mentioning earlier, the idea of forgetting about this local preference and just offering it to whoever in the U.S. Ranks highest on this wait list. And then we could look at the time they were starting to implement this idea of the MELD score, so we could look at those policies as well. So other questions we can explore, those regions I show you were some arbitrary grouping of these OPOs into regions. What if we change the way we group OPOs into regions? That's one question. What if we offered the liver to the patient that has the most to gain from this particular liver, rather than necessarily the sickest patient? These might not be the same patients. And UNOS is actually looking at exactly this kind of allocation policy for donation in the U.S. We didn't look at costs in our model, but we could look at cost effectiveness of these different allocation policies, which is of interest to policymakers. Just to give you a sense of the data that went into this model, so for these natural history disease progression models, we needed detailed longitudinal data of patients prior to transplant. So we had data available to us from the University of Pittsburgh Medical Center to do that. A lot of our data on patient generation, how many patients are listing for transplant each year, what's the breakdown by different demographic factors, came from UNOS, as well as information on how frequently organs become available and with what characteristics. Okay, so let me talk a bit about research collaborations that Dr. Guan and I and colleagues at the Sauder School of Business have started looking into. So one is optimal path planning for laparoscopic surgery. So the issue here is that the exact location of some critical structures is unknown during the course of surgery. So we have preoperative imaging, which of course helps surgeons have a good idea of where things should be, but there is uncertainty in the precise boundaries from these images of where things are. Also, these images are sometimes taken weeks before the actual day of operation, with a patient in some different physical orientation than day of surgery. So that's another reason that things might not be exactly where we thought they were. And so this location uncertainty makes it challenging to reach a target organ, such as kidney for nephrectomy, safely and efficiently. So what we're interested in looking at is how could we take this initial location uncertainty, combined with information gathered along the way through the information that's coming through the video camera and the surgeon's expertise about what they're seeing, and try to make suggestions about which direction to cut into next. This is not dissimilar from the question I mentioned earlier about the optimal routing of FedEx trucks. Okay, so this is a classic problem in operations research. What is the optimal way to get from some origin to destination? And in this case, we have, for example, some unknown the exact location of where some cliffs are as we're taking these trucks from some origin to some destination. Okay, so we're looking at analogies between this problem and other problems looked at in operations research along those lines to try to inform decision making here. So another question that we're starting to look at with our research assistant Candice Chan is reevaluating the living donor process. And so both potential recipients and donors go through several tests to determine if each one is suitable for either receiving a donation or providing a donation. So are all of these tests needed? Should the sequence be different? How can we reduce turnaround time from patient referral to living donor transplant? I think Dr. Seth mentioned that's around 351 days. And when should the potential donors begin their evaluations? So just to give a flavor of that kind of decision problem, one option is to start the donor stream of tests exactly when the recipient starts, if a donor is identified. So just suppose, for simplicity, that we have these 5 different tests. They take the same amount of time, and they both go through these tests at the same time. So the recipient and donor both pass through test 1 to determine eligibility, test 2 and 3, but then test 4, the recipient, we find the value that comes out of this test makes them ineligible for transplant. So what happens here is that we wasted many tests, okay, and the cost of these tests, the time involved, and the inconvenience for the donor, because it turns out that they just couldn't donate in this recipient. So it was a waste. So another option is to stagger it this way, have the donor set of sequence of tests start after we know that the recipient has already passed all these tests, right? Of course, the downside here is that if that's the case, we had this unnecessary delay because ultimately they all passed all tests, so it would have been better to start people at the same time. And what if we have multiple candidate donors? How should we time those? Who should we decide who should start which sequence of tests when? Do we start both donors, potential donors at the same time, and so forth? So we could extend this idea to multiple donors. And Dr. Seth also mentioned about reevaluating donor exclusion criteria. So when should we decide when there's an X in one of these boxes and when we put a check mark? Should we consider the donor's risk preferences, the level of their relationship to the intended recipient, so that if it's my spouse who I have to take to dialysis every week, then maybe I'm willing to take on more risk, and I'd like to try to convince you that my life, the combined quality of life between my wife and me, would be much better if you let me move beyond these usual exclusion criteria and consider me for donation. So we want to look at patient decision models from the donor perspective. People have looked at living donor donation decision problems from the recipient perspective. When should they take an available donor? But we haven't seen that anybody's looked at it from the donor perspective. So we want to look at that as well. I want to discuss briefly lean principles in healthcare. Some of you may have heard about applying lean ideas to healthcare. There's a growing momentum in this. So lean thinking grew out of management ideas with the Toyota production system. The idea is to eliminate waste throughout the system, and you have this spirit of continuous improvement is what they say. So there's been recent interest in applying these ideas to healthcare. For example, to reduce unnecessary movements of patients, of physicians, nurses, of documents. Okay, so change the way you configure the physical layout of some things to reduce waste in movement, and to reduce medical errors. So I think some of you may have seen the recent news story about the New England Journal of Medicine article about how using surgical checklists reduces medical errors. Okay, so this is an idea of lean principles, and better labeling of medications to reduce medical errors as well. So in terms of lean and OR, how do they compare and contrast? Well, they could be used in combination. So lean principles may be applied initially to helps us take a step back and get a bigger picture view of what's going on. Okay. And see things that we might not see when we're working in our silos and not getting the big picture. Okay. So this helps us see where clear efficiency gains may be realized. It's often things that when we take a step back and look at it, it seems like common sense in hindsight to do many of these things. And then operations research modeling would be useful then if the effects of changes are not so clear and we require more analytics, more machinery to help evaluate these different cost-benefit trade-offs. They're not clear. You can't do a rough back-of-the-envelope calculation to decide if one approach is better than another. Okay, some observations to wrap up. Major decisions about healthcare resources and patient treatment should not be made without careful analysis. And operations research methodologies provide a systematic way, an analytical approach for looking at different complex processes and the possible downstream effects of different choices. Now we could apply these techniques to both systems level analyses, looking at staffing, scheduling, location decisions, as well as patient level analyses. When to treat a patient, how to treat a patient, and so forth. There's a growing interest in applying operations research techniques to healthcare. They are challenging, they can produce good basic and applied research, and most importantly, they can benefit the public. And it's important that we collect data and save it over time so that we could validate these models. These models, there's a saying that you have garbage in, garbage out. So if you don't have good data to drive these models, they're not going to be useful. And then if you're interested in some further reading, I have this slide of references. And I should just also mention that I mentioned these projects we do through our master's degree program and how it places students working with various industries and often with various health authorities. We have 1 or 2 slots we're still looking to fill for projects that would start this April or May. So if any of these types of studies interest you, let me know. Students do excellent work, as evidenced by our 2 students here. Okay, thank you.